Yes, ma'am.
So are we live, Bhavya?
Yeah, just a minute. Yes, we are.
Yeah. So hello everyone, a very good afternoon. On behalf of the Optometry Council of India, I extend a warm welcome to all of you who have joined us on the Zoom platform as well as on Facebook Live. For all those who have been following the lecture series, this is the Optometry Council of India and Essilor Knowledge Series. It's a series of lectures on presbyopia related topics. So we have already covered 4 topics in the past, and these lectures happen once in 2 months. So this is the 5th lecture of the lecture series, and today's topic is on some interesting case discussions on progressive addition lenses. And to present this talk, we have none other than Mr. Preeti Singh Rekhi. He's a very renowned and well-known optometrist in the South. He's based in Chennai. Before I move on to give a brief intro about the speaker for the day, a couple of announcements. So we'll have a couple of poll questions in the midst of this talk. So you can give in your responses on the Zoom platform. And for all those who have joined over on Facebook Live, you can just type in your answers in the chat box and we will accept that as well. And if you have any questions pertaining to the talk, you can type in the chat box, both on Zoom as well as on the Facebook page. We will take that up at the end of this. Joining Mr. Preeti Singh Rekhi is Ms. Anantalakshmi, who's the Professional Services Head for Essilor Luxottica India. She will be one of the panelists post the talk by Mr. Preeti Singh Rekhi. And to give a brief intro about the speaker for the day, we have Mr. Preeti Singh Rekhi, who has done his baccalaureate of optometry from the Elite School of Optometry. And it's my pride and privilege to introduce him to you all. He happens to be my senior from college. We are all alumni of Elite School of Optometry. He has received advanced training in the clinic of Dr. Can Chatwal in Ontario, Canada, and American Optometry Association accredited advanced contact lens training program in New York in the year 1991. He has held many academic positions in the past, and he's currently the honorary faculty of the Rehabilitation Council of India's Orientation of Medical Officers working in primary health centers for disability management. He is the honorary faculty for the postgraduate diploma in special education for persons with multiple disabilities. He is the external examiner for graduating optometrists from Lotus College of Optometry since 2004. And he is the guest faculty at the Reserve Bank of India Staff College. He has held honorary optometry post to the Spastic Society of India, the Down Syndrome Federation of India, as well as the Down Syndrome Association of Tamil Nadu. He's also successfully conducted Special Olympic camps in the past, and he has conducted an instruction course and delivered a lecture on being invited by the All India Ophthalmic Society for their meetings in Bhopal as well as Hyderabad. He's established the Spectrum Eye Care Clinic, which was established in 1991, and he offers comprehensive eye examination services to all ever since. And he also happens to be the star of the comprehensive eye examination video, which the Optometry Council of India launched last year. So please tune in until the last, because we will be showcasing the YouTube again at the end of this lecture. So without any delay, over to you, Mr. Preeti Singh.
Thank you, Anita, for that lovely introduction. It's a bit long. Can I share my screen now?
Yeah, you can do it now, Rekhi.
Is it coming up?
Yeah, it's on. You have to go to the presentation mode.
Okay. So good afternoon, everybody, and thank you so much
Not on slideshow, Rekhi.
Sorry?
It's not on slideshow.
It is on slideshow.
Okay. We can still see multiple slides in the side. Can you stop sharing and share again?
Okay, is it changing?
No.
No.
Okay.
So in case you went to the other mode after sharing, then it doesn't. So you have to, okay. Now click on, yeah.
Is it on now?
Has it changed for you?
It's changed for me even earlier.
Yeah, now what you have to do is you have to go to stop share and share the full screen rather than the earlier screen.
Come on.
Yeah, perfect. Yes.
Okay. Sorry about this glitch. Good afternoon, everybody. So today we are talking about this interesting cases and discussions on progressive addition lenses. So I thought what I would do is talk a little bit about some errors that are occurred that we tend to do quite often. So hold on, this thing is not changing. So an uncomfortable spectacle is a potential loss for many patients when we prescribe these kind of glasses. And there's nothing worse than a patient buying an expensive pair of glasses with great progressives, expensive progressives, and the patient is not able to wear it. And on troubleshooting, you find that there is really nothing wrong with your prescription or nothing wrong with the lenses that you have prescribed, nothing wrong with the fitting, nothing wrong with the frame. So why is the patient not being able to adjust? This is one of our bigger problems that we face in the clinic today. So I thought I'd talk a little bit about the whole process. So somebody in your clinic, if it is you or you have somebody else who's I would not advise an optician to do this, or I would advise somebody who will describe a lens or be a lens consultant to prescribe the lens, which is what I mean is you have a prescription with you, but which kind of lens do you prescribe is decided by either you or by the lens consultant. So typically what I would expect is that the flow of the prescription process should be the prescription is given by a consultant, and then you have a selection of the lens. Then you get the selection of a frame depending on the type of lens that you've selected. Then, of course, the processing takes place, the quality checks are done, and then finally the delivery takes place. So when you have errors can occur in many areas. You can have an error in the prescription, you can have an error in the dispensing by the different measurements. And dispensing errors are more to do with the frame, the wrap, the pantoscopic tilt, the vertex distance, monocular PD heights, etc., and the type of progressive that is done. We are going to concentrate a lot more today on the prescription part of it because that's where we come in. So I've divided this whole thing into a few cases. And for the sake of simplicity, I've kind of simplified the prescriptions of the cases to make my point. Most of these cases actually came to us for second opinions, and we managed to sort it out. So I'm going to go through this. So the case one is when a patient came for a routine checkup, 39-year-old. This wasn't a second opinion. This was my own case. And he is a 39-year-old male, uses a desktop computer for 8 hours a day. His previous class prescription is 2.75 roughly. His visual acuity was 6.6 partial and 8. Now, what we found at that point was, this is way back in 93, 94, we had prescribed him a -3 because his vision improved to 6.6, 6.5, and he had an add of +1. What we found is that the patient wasn't very happy and he actually prefers the previous class prescription. And in this sort of a situation, what mistake that we had made was that if you actually look at the lens values, you're talking about a distance value of -3 and a reading value of -2. And what he's currently wearing is a 2.75, which is a 0.25 undercorrection, and it's a 0.25 add, whichever way you want to look at it. So basically, I was improving his near vision only with a 0.75 add compared to what he was wearing. he was essentially asymptomatic. And the mistake that we had made was to give him that slightly better distance vision from 6/6 partial to 6/6 plus, and his near vision improved from N8 to N6. The problem was that when you give him a progressive, doesn't have the kind of field of view that he's got with his distance vision glasses. So the other problem that we found was that he really wasn't 39 years of age. He was actually about 41. And his real date of birth was slightly different. So this also is pertinent. We are a little bit more careful about this nowadays, that when a person comes to us who's in the late 30s and there's an increase in his myopia, even if it's a single vision, we don't really change the glasses unless we actually verify exactly what his real date of birth is and what is his actual ad at that point. Now, I don't know how many of you test ads using a cross cylinder and a vertical and horizontal lines, but that's the correct method to get the actual assessment of what the ad should be. So case 2 is a little different. This was a second opinion. A patient had come for a routine checkup, 45-year-old female. She uses laptops essentially, so which is a little closer. Previous class prescription was -1. Visual acuity was 6/6 and 12. And she was prescribed a -1 and an addition of 1.5, with which she had 6/6 and 6, and she was not happy. Why do you think this would be the situation? Because her distance vision remains exactly the same. And if the person who had prescribed these glasses to her had actually asked her how she uses glasses, she would have very told him that she wears the glasses to office, and that once she's in office, she removes the glasses, works through the day, and puts her glasses back on when she wants to drive back home. So when you give her a progressive, technically, yes, you've improved her near vision at 40 centimeters by that 0.5 ad. But if she holds things a little further away, her field of vision is so narrow that that 1.5 ad progressive actually is worse than her just removing her glasses and seeing. The only situation where the progressive might work is if she's in consistent meetings where she has to look at a presentation, look at her desktop, look at her talk to people, and you're doing simultaneous things, then yes, that prescription works. Otherwise, just the -1, and she'll take off her glasses and function all the time. So what we did was we told her to use her previous class prescriptions or her progressive edition lenses as distance glasses and take off in the office. So this is a person you will have to wait for her reading part to reach around a +1 or a +1.25 before she might start wearing glasses or progressives all the time. So these are cases typically when you find between -0.75 to 1.25, sometimes even 1.5, that people don't really end up wearing progressives if you prescribe them. And the problem is they end up spending a lot of money, and then they say, you know what, the older glasses were better. Your reputation goes down. You can anticipate these problems and then prescribe a glass and say that, you know, maybe use the progressive only for these purposes. Then I think to some extent you are justified. So here we've got a 40-year-old female who's unhappy with her new glasses. This is a case that we actually did, I think about 7 months ago. And she was prescribed about a month before she came to me, -4.5 with an ad of +1. Her classes were 4.25. She gave a history of a lot of stress. And what we found was that I found certain signs of, so that there are certain things that we are beginning to look at now, and we use a lot of binasal. So I stuck the patch on, left it on for about 10-15 minutes, used a little bit of temporal stimulation. And we found that she was actually, and for her age, with a cross cylinder, my ad was only +0.5. So in many ways, the older prescription was good because the reading part was 3.5 instead of what she was wearing, 4.25. But her distance actually was only a -4. So what we did in this case was we just gave her a -4 and just told her to wear those all the time. And she seems to be extremely happy with it. I saw her a couple of weeks back and she is still very happy with the single vision lenses. And she's not wearing her distance vision glasses, the progressives at all. So the concept of increasing myopia, I think needs to be looked at, because if you get somebody who is in their late 20s or mid 20s, 40s, who are now suddenly showing an increase in myopia, and you're not seeing any signs in the eye, I think we need to be aware that these are people who, in the last 3-4 years, have been spending a lot of time in front of near devices, and they are getting a certain amount of an accommodative spasm. So one option is do a strong cycloplegic refraction. Alternatively, just see if you can fog them a little bit and see whether you can down the power. The other alternative is if you have their older glasses which are slightly underpowered, just stick a binasal patch on it, wait for a little while, and just see if your refraction changes. It is unbelievable how quickly it works. Yesterday also we had a young girl who walked in who's progressive edition lens wearers, people who got moderate powers or low powers, you have to be very, very careful with the increasing myopia and then giving an ad, because you may solve one problem, but you create another. Can you guys hear me? I'm getting a message saying my connection is a little unstable.
Yes, we lost you in between, Reiki.
When was that, roughly?
Just a couple of seconds back. I thought it was an error at my end.
No, I got a message. Anyway, it's okay. So I think we can go to the next case. Did people do you think people understood the concept of the binasal patch, or do you want me to go through it again?
If you can just repeat.
So basically, what we're saying is that people above the age of 20, where you or 23, 24, and especially since we're talking about progressive addition lenses, people who are first-time wearers who are in their 40s, late 30s, early 40s, if there has been an increase in myopia, be aware of the fact that this could be an accommodative spasm rather than an actual increase in myopia, which will then make you prescribe something that they're not very comfortable with. So it's probably better to look for this and be aware that this is a possibility. So the next case that I've got is a 44-year-old female who came for a routine checkup. Her previous glass prescription is -8. We also found a -8. And we got an ad of 1.25, which is a little bit low for her age, but it seemed all right. Now she uses her laptop more than she uses her desktop. So what kind of advice do you think we can give to this person? So what you have to be aware of here is that a lot of high myopes actually do not adapt to progressives very quickly. I think Essilor is going to not like me for saying a lot of this. I prefer to prescribe progressives a little later rather than earlier, because I'm a little afraid that when somebody spends, for example, if you give this person a decent progressive with an ultra thin lens, you're talking about a spectacle which is about 30, 35, 40,000 rupees. And I don't want them buying it and saying that, the older glasses work better. So when you have a -8 and they just slide it down the nose slightly, it becomes a 7.5. And they can actually see the computer and the field of view so much better than through a progressive. I think the needs of the patient have to be taken into a significant amount of consideration before we decide what kind of lens to give. The same patient, if they were in a situation where they're constantly seeing far, constantly seeing something in the better. The other thing is that I've made a point here that they use the laptop more than they use the desktop. The reason is when you are looking at the laptop, if this is the spectacle, this is your line of sight for seeing distance. This is your line of sight when you're seeing something for near. And the vertex distance tends to increase. And in most of these people, you'll find that if you hold a reading card in front of them, keep their head steady and bring the reading card down, that they're actually able to read a little bit better. So most of them already have a system where they actually lift their chin up a little bit and read, because they're enjoying that 0.5 ad already that exists in that lens. it comes as a result of the vertex distance being more, and when your angle of attack to the lens is a little bit different. So giving them a +1 ad or a 1.25 ad, I would say in 9 out of 10 cases is not going to be beneficial. A lot of them will just slide the glasses down the nose and they say, you know what, I need better with this. This is just my view, my thoughts. And on the other hand, if a person is going to be wearing, let's say glasses at -10 or whatever is your distance high power, and they use the computer for 10 hours a day non-stop, they may actually not be as comfortable with a pair of progressives because your field of view is going to be so much narrower through the intermediate zone. A regressive might work better. So sometimes in this sort of a situation, I love using this acronym, which is BLA, which is best left alone. Some of these patients are better left alone. Give them systems by which they can hold the glasses a little further away, adjust the position of the reading material, and postpone the introduction of a progressives maybe a little longer. Very quickly on to case 5. This is a case I purposely brought out because it's a 13-year-old girl. This is a case that I had done, I think, way back in 94, 95. And this girl today lives in New York and she still is a patient of mine. And people haven't been able to do what we did for her. So she had come for a second opinion and she was prescribed a -4.5. And her previous classes were -3.5 and she continued to prefer to use them. And no matter what, every time she went back to the doc and saying, I'm not comfortable with the 4.5, they would recheck the powers and find that 4.5 is a perfect power. And she actually had 612 vision with it, and with a 4.5 of vision is 6.5 and 6 whatever. What they hadn't tested for was, so even when you check the spectacles, everything was made correctly. The PDs were right, the adjustments were right, the pantoscopic tilt was right, everything was okay. What they hadn't checked was that with the previous class prescription, she was ortho at near. And this is a very common error that we all make because whenever we test for muscle balance, we tend to do it with the previous class prescription, not with the new class prescription. So if a patient has an increase in myopia and with the previous class prescriptions was ortho at near, with the newer class, they are obviously going to be esophoric at near, which is going to create headaches. So this patient obviously had ESO at near and was a high AC over 8 patient. So the solution for this is multiple. One of the solutions is that now it's kind of difficult to do this because the patient has gotten used to seeing distance clearly with a 4.5. But right in the beginning, could you have just increased the power by 0.25 or 0.5 and given them vision from 612 to 6.9 and left them asymptomatic for near, which is what she was doing. She was a voracious reader. That's one alternative. The other concept would have been to maybe either correct her fully or slightly undercorrect her and incorporate prisms by decentration, which is what we initially did for her. But she had already sort of gotten used to the 4.5 distance prescription. The other alternative is that you give her a progressive with a 0.75 or a 1 ad, which or a regressive. Regressives actually work very good for this. Initially, we didn't have regressives in those days, but we had given her progressives and it worked wonders with this girl. So the reason I wanted to bring up this case is that do not eliminate the use of progressives in the pediatric population. There are a lot of people who tend to go undiagnosed and they are symptomatic. So a lot of these kids will remove their glasses and read. And in a classroom environment or in maybe a professional environment, it becomes a little difficult. And a progressive can help. And I find that when you're giving low ads, the regressives tend to work a little better because your field of view is a lot better. The only word of caution on it would be that if you're using, let's say it's a plus power, then a regressive becomes a bit of an issue because suppose you have, let's say, a +1 with a 2 ad. A regressive becomes a problem because it's manufactured at 3. That's at the full reading power. So the lenses are thicker. And I think there are very few companies that give you ultra thin regressives. But that's a concept that you can contemplate. So case 6, is a little bit different. Okay, so we got a 55-year-old female who uses laptop 4 hours per day. Her previous glasses are 4 years old, plus 4 with an add of 2. And she's complaining of a decrease in near vision. Her vision is 6.6 partial and 10. Refraction is 4.5 with an add of 2.5. So here you have a bit of a problem, because if you look at these numbers, her distance prescription is 4, and there's in the previous classes, and the reading is 6. And when she lifts her chin up slightly, she will start seeing clearer for distance. Also, she's beginning to lift her chin up a lot more to be able to see. Also, I know the glasses are 4 years old. So one of the first things that I ask a patient like this is that, are you suffering from a neck pain, or do you, tend to touch your neck like this towards the middle of the day? And invariably the answer is that, because their whole day, their neck is, instead of being angled straight, it's at a little bit of an angle like this throughout the day. We've actually had patients who've been diagnosed with spondylitis. We change their glasses and the spondylitis disappears. So be careful. There's a lot of neck compression that takes place whenever the shift is towards the hyperopic side. Now, the reason I put this prescription up is her reading power in the older glasses is 6. What you're going to be prescribing is 7. There's a +1 jump in power. So whenever you have a hyperop, where the powers are changing this much, it makes life easier if the previous glasses were made with a second generation lens or a soft design lens, where the reading zone is a little small. Then it's easy because you can increase the power. And when you have a +6 versus a +7, or obviously a +7 has greater magnification. So I want a wider reading area to negate the magnification effect and therefore keep the field better. You can always up a patient from a soft design to a hard design. In one way, it's a hard design, it's an older design, so maybe you're downgrading them. But then basically what we're looking at is a lens with a wider reading zone. The intermediate is not as critical for them. And when you do that, it's easier to prescribe the full prescription. On the other hand, if you don't, let's say they're used to the same lens and you make a +1 change in power, invariably the 2 complaints that they will give you is they'll say that I can't walk properly. That's because the older lenses, the actual power is a little lower down. 4 is here, 4.5 is here. So when they stand straight, they're actually able to see things at a lower level very clearly. And whereas when you shift the power up, the core of distance vision becomes significantly reduced. Walking becomes a problem. The second is when they're looking at their laptop, which is a little further away, they're using the lowest portion of the lens, which has a power of 6, and that has a very wide field of vision. When you prescribe a 7, the 6 is a little higher up in the lens and it's through a narrower zone, so your field of vision narrows down. So you have to tell them when you prescribe that these issues are going to happen. And I've always found in my practice that if you're predictive about potential problems, the advantage is that when the patient experiences that problem, they say, oh, all right, this is what I'm supposed to be seeing. And that negative experience actually becomes a positive experience, saying that, oh, okay, this is to be expected. Whereas if you don't say that, walking is going to be a little difficult, the field is going to be a little narrow, but reading will be better. If you don't give them these instructions and they say that, you know what, I can't see the computer as well as I could with my older glasses, then they come back to you. Then you have to explain it. So why not just say it right in the beginning? The other alternative is that you can, so this is what we were talking about, improve the near vision at the expense of mobility, field of vision and laptop. The other thing you can do is actually maybe make the distance power 4.25 and give an add of 225. So reduce the impact of the change in 2 steps rather than doing a complete +1 difference. With a lot of hyperopes, I find that more than a 0.5, maximum 0.75 change, it's very difficult for them to adapt. Okay. Case 7, 60-year-old male, Sorry, can I just go through that? I'll come. There's some questions in the chat. Can I come to them a little bit later?
Yes.
Okay. So there's a 60-year-old male. His previous class prescription is right eye was -3. The left eye vision is 6/9. Left eye is -4, 6, 18, and the addition is 2.5. Now, in our refraction, we found that the right eye had reduced a little bit to 2.5, vision improved to 6.6. Left eye had increased 5.5, 6.12. There was a certain amount of nuclear sclerosis in the left eye, which kind of accounted for the increase in myopia. And in the other eye, there were some cortical changes, which again accounted for the reduction in the myopia. Now, here you have to understand, you have to be extremely careful. One is you're increasing the anisometropia between the two lenses. So what happens is that if you do prescribe this, in your clinic, when you measure the distance vision, and even if you compare it with the 3 and 4, they'll definitely say the 250, 550 is better because they're fusing better. It's within the 3 diopter range. All that is fine. The problem is that in the progressive, when you go up and down in the lens, there's a fair amount of distance you have to travel down, and the anisometropia will result in a vertical phoria for this person. He's used to a 1 diopter difference. There are patients who react if you change it by more than 1. So if you can go to 3 to 5 maybe, but more than that, they will react. So you have to be a little bit careful. If this person, for some reason, if you have got his old records, you find out that the left eye is actually amblyopic, don't worry about it. Freely go ahead and prescribe the 250, 550. Amblyopes have a much larger vertical fusional range than regular people do. However, if you speak to the lens manufacturers, they would prefer that you have an anisometropia of a 2.5 for a progressive. More than that, they feel that it will result in symptoms. But I find that you can actually push a patient up to 3, especially if they've been used to it already earlier, if they're used to a slight anisometropia. Now, there are interesting cases where you have patients who've got a very large amount of anisometropia, but they don't have diplopia. So I don't know if you're aware of Knapp's rule, where the difference in myopia is more due to the axial length difference between the eyes. In those sort of a situation, then even if you've got -2 in one eye, -9 in the other, they'll actually fuse beautifully. There will be no anisoconia as a result. In those kind of patients, again, you can prescribe progressives, but remember the vertical prism difference is still going to be there. So it is a bit of a worry prescribing progressives for them. Some people adjust, some people don't. They will fuse, there is no doubt about it. So in some of these people, what I prefer to do is use a short corridor, because the distance between the distance viewing point at the bottom is less, and therefore the vertical disparity tends to be a little bit less as you go down at the lens, and it tends to get hidden a little bit more. So we've got another 10 minutes more. So what I'll do is, I want you to look at a couple of prescriptions, and I want you to understand firstly what the prescription means, what the patient is going to experience when they wear these glasses. So I've put up a prescription for which I want you to answer a simple question. Do you prescribe progressives or do you not? And I think Anita has got some polls coming out for this. Anita, this is the first slide.
Sure.
This is the prescription.
Shall I launch the poll?
Please launch the poll. So I'd like you guys to answer this so that we can have a look at it and see what the kind of results are. I don't think you guys should be shy.
10 seconds more, and I will end the poll. Yes, I'm going to end the poll now. So I'm sharing the results. So
Okay, I think I've got 16, what 89% say yes, and we got 11% who say no. Okay, so what I want you guys to do is look at this spectacle. What is the distance power? It's a +1 with a -1 at 90. Now, what this means is that if you take your lens and you move it vertically up and down, the power is what? It's a +1. When you move it this way, the power is 0. Now, the other eye, if you move it this way, the power is 1.25. If you move it this way, the power is -0.25. Now, when you have a plus in one eye and a negative in the other eye, when you go up, you're getting a vertical disparity taking place, which is extremely rapidly changing. And when you go down, you're getting again a vertical disparity, which is very rapid. This is a patient, if you prescribe the progressives, they'll be extremely uncomfortable at near because they will start having mild diplopia. They will not say double vision, they'll actually say it's a blur, but in reality, it's a slight double vision. A lot of these patients are highly symptomatic when you prescribe a pair of progressives to them. What you have to do is learn to look at the lens from that aspect. So as a follow-up question to this, let's look at the next prescription. And let's have a poll for this and see how many people would prescribe glasses for this, a progressive for this. Anita, can you put up the poll, please?
yes, the poll question is up. I'll be ending the poll in 10 more seconds. So I'm sharing the results.
Okay, so we got 72% who say yes and 28% who say no. So good. This is a perfect progressive prescription because when you go vertically up and down in this lens, the power is -2. The left eye is again -2. So when you go vertically up and down in this prescription, it is a perfect progressive prescription. This is by far the easiest. Do not get fooled by the plus spherical and the minus spherical. What you have to look is at that 180 axis, vertically up and down, what is the lens? So I have another question, another prescription here for you, which is interesting. I thought I'd have a poll for this, but I think the answers are too many. One is to find out what is the error here, or firstly, is there an error here? And if you look at the prescription extremely carefully, you'll see that the right eye has an add of 2 and the left eye has an add of 225. Now, I see less and less and less of these kind of prescriptions coming out of hospitals, but many years ago, I remember it was very common to see a patient who came out with a +2 add in one eye and a 2.5 add in the other, which is ridiculous because as long as you've got normal eyes, a normal amount of accommodation, and you've never had an injury, why would one eye accommodate more than the other? So typically you expect adds to be equal. Yes, there are rare circumstances in which the adds will be different. One, of course, if you've got a cataract surgery done in one eye and it's plano in the other, I mean, it's a phakic eye in one and a aphakic eye in the other, or pseudophakic eye. The other option is, like, we had one patient of ours who had come to us for the review, a second opinion. He'd had a tennis ball injury, following which he was 43, 44 at that time. And post that, he had gone to a hospital and they had prescribed him glasses, of course, after all the treatment was done. And he ended up with the spectacle, which was a +1 add in both eyes. In reality, he had a 0.5 add in one and 1 add in the other. And that continued right up till the age of about 55, where he had 250 add in one and 225 in the other. There was always a little bit of a lag. And the only way you can find out about this differential is use the test You must have a system where your reading card is kept at either eye. You can do it monocularly, you can do it binocularly, but you have. Can you hear me?
Reiki,
Anita?
can you repeat the last few sentences?
Okay, so when you have a patient with a differential ad, what you have to be careful about is if he's had no problems, then there should be no reason to have a differential ad. The only reason I can think of where you will have a differential ad is if the patient has had a blunt injury in one eye, which has caused a problem with the zonules or with the ciliary muscle, and therefore one eye accommodates more than the other. Alternatively, one eye is sort of faking, one eye is faking. Then yes, one eye is faking. Then yes, you will have a differential ad. The thing to do is the way to test for it, especially when you have a patient who's had a blunt injury with a tennis ball or a shuttlecock or a table tennis ball or whatever. Post that, get them to see near, and over the distance prescription, you put a cross cylinder, which is aligned vertically, 90, 180, and you present them with vertical lines. Now, what happens is when there are 4, 5 vertical lines and 4, 5 horizontal lines, when you put a cross cylinder, it splits, and then you don't know which one to see. So if especially in my instrument, for example, if the patient says the horizontal is better, I keep increasing the ad. So it's pretty much like a duochrome test. If the ad is 2, with 175, the horizontal will be better. With 2, they will be both equal. With 2.25, the vertical will be darker. It's a very simple test to do. I generally do it binocularly, but in patients where I'm suspecting that there is a damage to the ciliary muscle, then I tend to use it monocularly. But this is, I brought this up mainly to say that these are things that you have to look at before you prescribe a progressive, because if you have a differential ad and you don't prescribe the differential ad, then the patient is going to be imbalanced. And over the years, I've discovered that it doesn't really matter if your prescription is perfect, but if the patient is focused on the same plane equally, and there's no imbalance between the right eye and the left eye, then they are generally speaking very comfortable. Which, just to sum up all of this, don't be too eager to prescribe progressive additions, especially the lower ads, because the rejection rates are a little higher in that. Be careful of low myopes because they prefer to remove their glasses and walk around. Most of them actually walk around without glasses quite often. They only use it for driving and TV and stuff like that. High myopes, be careful because they can actually look at it from a lower angle and see a little bit better. So wait till the ad increases a little bit before you prescribe. I don't know, a lot of this is going against what some people are saying, that they want you to prescribe glasses at progressives at an earlier age because it helps in certain things, but it's worked for me. Be careful when you increase hyperopia because you will affect mobility and you will affect field of vision. Unless, of course, you up the thing. So remember, many times I've had patients coming to me wearing 60, 70,000 rupee progressives, and I give them a third generation progressive with the same prescription and they see better. Because the third generation progressives or the hard design progressives tend to have much wider reading zones at the compromise of an intermediate zone, slightly narrow. But it's better for reading when you have got a high, if you got a +7 or a +8 in the reading zone, I want a wide reading area. So anisometropia is another thing you need to be careful of. If it's amblyopic, don't worry. If it is Knapp's rule, there are other issues that come in, but keep in mind that as you go vertically up and down, prisms come into play. Incorrect understanding of the prescription. That was my prescription 1, prescription 2. If you've understood that, that should solve the problem. The other is the design of the progressive addition meds, which also has a role to play in your prescription process. So we always look at what a patient is wearing before we decide. Sometimes an upgrade is not necessarily a better way to go. Sometimes just sticking to whatever they're used to is good. Knowing which design that they are wearing gives you an insight as to what they're comfortable with. And you also know that if you change, how are you going to make their vision better? And if you can predict that, then you're not really selling the lens, you're actually telling them how it's going to be better for you, and therefore they should take it. So it makes a lot of a difference in your ability to be able to do this. So thank you. I think we finished with about a minute to spare. I'll be happy to take any questions that you may have.
Thank you so much, Reiki, for that wonderful talk. I mean, there are many great tips that you have shared with us. Of course, it comes with tons of experience that you have in this field of dispensing. I really liked the acronym that you use, BLA, Best Left Alone. I'm going to start using that as
That's
well
my
now.
favorite.
Yeah, that's very nice. And also, you kind of, reiterated the importance of testing all aspects, not just leave the muscle balance checking with a new prescription is definitely called for. We tend to ignore that at most times. And also, from the entire talk, what I take away from that is prescription analysis is very, very important. You need to really thoroughly study the prescription, know what are the needs of the patient, and then take a call on what best would fit this patient. So it is a wonderful talk and a great learning for all of us. I'm sure most of you would agree to this. So let me take up a couple of questions. So the very first question was, I think this was pertaining to the first case that you had shared, Reiki. So they want to know what is 1/13 in that slide that you had showed.
Hold on a moment. Can I put up the slide?
Yes, you may.
Yeah. Is this the slide they are talking about?
Or maybe prior to this, I remember seeing this as well.
This is the first case.
No, earlier, did you share any or discuss any cases which did mention 1/12?
No, 1/12 was 1 month ago. I think it was case 3. This is a 40-year-old female who was unhappy with her new prescription. She'd come to a second opinion. 1 month ago, she was prescribed 4.5. Is this the thing that you're talking about?
I think the person.
I think there was a note in the chat saying third case.
Okay. So I'm not sure
This is regarding the month follow-up month.
So no, this is 1/13. So there's no mention of 1/13.
I don't remember unless I made an error and put 1/13 somewhere, but I don't think so.
Okay. So another question is, what is this test called? You did mention use of cross cylinders while prescribing ads. So what is that test called?
So let me show it to you. So what we have is in my
if you can stop sharing the screen, Reiki, your video, I can pin it.
Oh, sorry. So here what I've got is I've got vision. If you guys can see this. Now, in this chart, there is a vertical and horizontal line.
Slightly towards you. Towards you.
Better? So basically, it's just a bunch of vertical and horizontal lines.
Yeah.
It's vertical lines and horizontal lines. And you put a cross cylinder, plus or minus 0.5 cross cylinder or minus 0.5 cross cylinder. So what it does is, when it is put at 40 centimeters in front of the patient, with the patient's distance, let's put some numbers. Let's say the patient is 40 years of age or 41 years of age, and he has a +1 distance prescription. So you've got the +1 in front, and you put this 40 centimeters away, and you put a cross cylinder in front of the eye, which is a plus or minus half cross cylinder. What that does is that splits the vertical and horizontal lines this way. So assume my patient's eye is here, right? This is where the testing is being done. Now, the vertical and horizontals are split this way. So the patient says horizontal is better. So you keep adding plus till they both become equal. So pretty much like the duochrome test. So if the add should be 1, you may end up with 0.75, the horizontal is blacker than the verticals. With 1, they are equal. With 1.25, the verticals are darker and the horizontals are not so good. So it gives you an objective analysis of what the power should be. Interestingly, one of the major benefits of this test is when you end up with a patient who comes at the age of 39 saying, I can't see it here, and most people will give a +1 and to him. If you do this test, sometimes I do it binocularly because I do a binocular distance balance. I find that the ad is sometimes 2. So I've now got 2 values. I've got a distance value of Plano and I've got a near value of 2, both of which he reads N6 and 6.6 with. Now, one of these values is wrong. So when I do this test, I know my +2 is correct because that 2 he comes. So he's obviously a latent hyperope. So then my prescription to him is different. I tell him, okay, I'm going to push you to a 5 with a 150 ad. Don't worry, people will look at you and say you're only 40. Why is he giving you a 1.5 ad? So there's a whole lot of discussion that goes on to it. And then gradually we can up his prescription. And when his power increases, he says, oh, ever since I wore your glasses, my distance power has gone up. So the whole idea as far as probably to go up to 1.25 or 1.5, I don't know. But it's more not an increase, it's a sort of an unraveling of your power rather than an increase in your power. So he's prepared for the next 5 years, what's going to happen. Everything is about being predictive. The more predictive you are, the longer the patient stays with you, I feel.
Thanks, Rekhi. So you did mention about binasal occlusion. So
Right.
how effective it is about in accommodative spasm cases?
So it does work. So for me, what I'm noticing of the last, I think the last 5 years, I've used binasal occlusion a lot. If I saw 10 patients, at least 4, I was sticking the tape on them. And it works on multiple aspects. It was really effective in reducing accommodative spasms. I found it within sometimes even 5 minutes, the patient's refraction changes. And the problem is binasal patch sometimes doesn't have the same impact to the patient as when you just sort of shake your hands like this and the patient. I have a patient where I know they are spasmic. So before I stick the binasal patch on, they're wearing, like yesterday, this girl had come, she had a -1.5 and the refraction was 2.5. And she's been stable at 1.5 for a long time. And so all I did is she wore her glasses, I refracted her. I knew that she was going through a spasm. So all I did is put her older glasses on. She was seeing 6/9 partial. And you just shake your hands like this in front of her face while she's trying to see something far away. It's pretty much the same as binasal patching, because you're getting the brain to see something here, and gradually her vision starts improving. And they're just like, what are you doing shaking your hands and my vision is improving? And then you explain the whole process of what you're going to be doing. And then the patient is so much more excited about working with you. And it becomes an ongoing process. Then, of course, we just stuck the tape on. She's got back. She had 6.6 by the time she left. It took us 15 minutes. So it's very, very effective. Try it. All I'm saying is stick it on. What difference does it make? Worst comes to worst, you're losing 5 minutes of patient's time and your time. But you're learning. Every time you're learning. And one of the other benefits of binasal patching is it has an effect on the parasympathetic system also. So that's quite exciting to work with.
Thanks, Rekhi. I did try this binasal occlusion once for a young patient of mine. After hearing you speak about it, I think we met at ASCON when you mentioned about this 3 years ago, just before the pandemic, I guess. So that's when I heard about it, and it really worked in the child's case. So there was no need.
It works very well. As a matter of fact, it's a ridiculous thing that today in Chennai, if people are shopping and they see a guy wearing a binasal patch, they say, oh, Spectrum Eye Care or Reiki's patient. I had a patient who met a girl after 10 years or 7 years in LA. He had come down from the US last week. So he was telling me, I met so-and-so and I had forgotten about this girl. And he's like, I met her. And then after about 1 hour of us meeting, she pulls out her glasses to watch TV. And she had this little tape stuck on it. I said, Reiki's patient, sir, how the hell do you know? So he said, no, he stuck these on me 5 years ago. So I kind of know where they're coming from. Anyway, these are all anecdotes, but it works. It really works.
So I guess we had one question on the Facebook chat. Person wants to know, how do we manage the difference in fitting heights? If a particular case demands a difference in fitting heights between the eyes, how do we manage them?
Write it on the file cover itself that this patient, sorry, my internet connection is unstable. Can you guys hear me?
Yes.
Yeah. So differential heights are differential heights. If your one eye is higher than the other, it is for life. It's like your PDs. PDs are not going to change. If you've got a monocular PD, let's say 31, 33, I don't think it's ever going to alter. It's going to be exactly the same unless the guy's nose breaks or something. And if you've got a differential fitting height, it has to be taken into account because the patient, otherwise, if you've got one eye higher than the other and you go down, one eye is already in the mid range and the other eye is still in the distance area. So that's a no-brainer. But you have to be 100% sure that the height differential exists. So take maybe multiple spectacles, take 3-4 measurements, be sure about it. And yes, if the patient is not used to it, then you have a problem. So if you have, for example, a patient who's used to a spectacle which is perfectly 30, let's say 64 is the PD and is 32, 32, and you find 30 and 34. Now, the thing is, he's used to moving his head off to one side to be able to see. So sometimes it's a judgment call whether you take that full 4 mm decentration immediately, or do you want to break it down into 2 millimeters first, then another millimeter, then another millimeter. But again, this is in discussion with the patient. You cannot do it unilaterally. You have to tell the patient, you know, this is what I'm seeing. And if you notice, you always read things with the paper to one side. What's the point of you doing a perfect job? He moves the paper to one side and he can't see because that's his muscle memory. So similarly with the differential height, maybe he's used to tilting his spectacle and seeing with it. So a lot of these things you have to be aware what the patient is wearing, what the patient is doing, how is he wearing his existing glasses. You may think you're doing a fantastic job, but the patient may be uncomfortable. So there's a difference between doing the right thing and doing something that gives the patient comfort. And I think that's the correct thing to do.
Anand, anything?
Agree, Reiki. In fact, I was about to tell this. In fact, I had actually seen one case like this when there was a differential height, but the patient was already using the level of heights were the same. And suddenly when you change it, what would happen is, so please understand, each customer or each patient is unique. You have to understand the current position and how you're going to change the current position to a new position. So you need to evaluate both the situations and see if there is going to be a difference in terms of this adaptation and comfort. And only then you have to give. There is, I agree with what Reiki rightly said. There's a difference between what is right and what is comfortable. I think you need to have a balance with both.
Where do you get these unique cases from?
All second opinions. That's the beauty. I'm very happy with them. Also, I think I've been around for a while, actually. I just completed 31 years in the clinic in December.
Wow.
So that's a long time.
A real long time. I guess there are no more questions from the audience, both on Zoom as well as from the FP audience. We don't have any more questions. So for all of you who have tuned in today, a big thank you. And I would also like to invite each one of you for the upcoming conference, which is being hosted by OCI to commemorate 10 years of its existence. It's called OCCon 2023, and we are hosting it at 5 venues. And the first of the venue is at Ahmedabad on 29th of January. On 5th of February, we are coming to Jaipur. On 12th February, we are coming to Guwahati. 19th of February, it is in Bangalore. And 26th of February, the last of the venue for OCCon 2023 is Kolkata. So do join us. The registration is open and it's going to be closing very soon. So we have
Posted
shared
the link.
the link for
Anita,
registration
I
has
posted
come
the
up in
link.
the chat box. It's available on all the social media platforms of Optometry Council of India. So we are very excited to host you all at each of the venues. So I look forward to meeting most of you at the venues. So look forward to that. And once again, I would like to extend a big thank you to the speaker of the day. It was a great learning experience personally for me, and I'm sure all of you would agree that you learned a lot from all the cases that were being presented. Each one were different in its own right, and a lot of learning came through. So before we wind up, I would like to share the screen.
I'd like to just say thank you so much, OCI and Essilor, as usual.
Thank you so much, Reiki. I think it was wonderful, as always.
So I just would like to say that this session is recorded for those of you, I think some of you are educators here as well. So if you're interested in, showing this to your students or in some kind of case discussions that you want to teach, just write to us and we'll be happy to share.
Also, all the previous lectures from the lecture series are available on our YouTube channel. So you can go access them in case you have missed any of those previous lectures.
Comprehensive eye examination does not involve checking of spectacle power alone. What else does it involve? Initially, the optometrist questions and records your problems or concerns with the eye and overall health. Once done, the optometrist checks your current vision. Once vision is checked, checking for any spectacle power is done using equipment such as the retinoscope. Following the same, the optometrist checks your vision with the spectacle power in place and arrives at an endpoint where your vision as well as comfort of spectacle power is recorded. Tests are also done to find if both eyes are in coordination in terms of functioning in unison. Following this, the optometrist enumerates the health of the eye using the slit lamp biomicroscope, an instrument mainly used to check the structures of the front part of the eye. Then, the intraocular pressure is measured and recorded. And finally, the retina, which is the back part of the eye, is assessed using equipment available at the optometrist's disposal. This completes a comprehensive eye examination procedure. Do contact your nearest optometrist for a comprehensive eye examination.
Anita, that thing had the cross-cylinder test.
Yes, I did notice.
Anita, do you want to share your screen and just show the dates and the venues, please, for OCCon?
I need to get that document out, Lakshmi.
Let me see if I can get it out quickly.
Ma'am, I have the image. You want me to share?
Yeah. Can you just share the screen, Bhavya?
Sakina, ma'am.
Oh, Sakina, sorry. Yeah, thank you. Thanks, Sakina.
Thanks, Sakina. These are the dates and the venues where we are hosting the one day. The agenda is focused more on, developing a independent optometry practice. So for those of you who are keen on setting up your own practice or who are already in practice, you want to, expand your practice, how you can use social media marketing as a tool to expand your practice. You get to take away a lot of learning from this one-day conference because we have called eminent speakers covering each of the areas of independent practice. What are the best practice standards? Then what is the minimum investment? With minimum investment, how can you gain maximally? That is being covered. then how to set up a practice in case you wish to sooner or later in your life, you wish to open your own practice. You can go ahead after hearing from speakers from each of these venues. And remember, the agenda is the same for all the venues. Speakers may vary, but we have ensured that the agenda, the theme, everything is same in all of the 5 venues. So a lot of learning which will come out from each of these venues. So I look forward to most of you registering for this conference, and I take this opportunity to invite each one of you personally to join us for this great Optometry Mahotsav 2023. Thank you so much for joining us again. A big thank you to Reiki once again, and Anant Lakshmi for joining us as well. And thanks to Bhavya and Sakina who have been behind the scenes and ensuring that this goes glitch-free. Thank you so much. And
Thank
thanks
you.
to Lakshmi.
Thanks, Anita, Lakshmi.
Thank
Reiki,
you.
thanks a lot.
everybody.
Thank you all. Bye.